Hello, and welcome to the perimenopause to postmenopause options for a comprehensive approach to care webinar. My name is Marnie. I'm a naturopathic doctor here at Annex Naturopathic Clinic. Sure. Ooh, make sure the slide works. Yep, looks like it's working. All right, so the overview of today's webinar, we're going to talk about menopause, really define what the menopausal transition is, and understand how it changes your health and who can support you through this process. We're also going to talk about the risks associated with aging and specifically menopause, as well as what we can change, what we can't change, and the approaches that we can take to care for ourselves. We're going to talk about hormone therapy because it's important to understand. Um, and we're going to differentiate between what's available. We'll also talk about the benefits and risks associated with hormone therapy, and then we're going to talk a little bit more about naturopathic menopausal care and what that looks like working with a naturopathic doctor. Okay. So a little bit about me. I'm celebrating 10 years of practice this May. I am the co-owner of Annex Naturopathic. I've been working with the menopausal, perimenopausal population my whole time in practice, but I've been prescribing menopausal hormone therapy since 2016, and a lot has changed and evolved even in this short amount of time. I love utilizing all of the naturopathic modalities, and I love supporting all health concerns and goals. A little bit about me outside the office. I'm a pretty adventurous person. I love being outside. My new love is surfing. I'm really having a lot of fun with that. I also ride a motorcycle and I have fun going on little trips, both in and outside the city and outside the country. I'm really into saunas and like making DIY ones that I can bring to farms and cottages and get-togethers. So that's one of my other loves outside the office is good old nature cure. Okay, enough about me. All right, why do women need comprehensive care? Well, women are unique because yes, age is a contributing factor to why things change. But then for women specifically, there's this huge hormonal shift that occurs in the menopausal transition that men don't typically get. So getting older and the menopausal transition are inevitable. So we do have to embrace it. It's important to inform ourselves. It's important to take a proactive approach, and it's important to make informed decisions that resonate with you. Um, I'm just going to make sure that just for 1 second, I'm just going to make sure if anyone else is joining that I can indeed add them in. Just let me stop my share for 1 sec. Okay, looks like we're good. Start the share again. Perfect. That is the last interruption. All right. Um, so moving on from just that basic, kind of simple principle of like two things are happening at the same time, and it's going to affect our health. So I like to be very aging positive, and I'm going to start with a poem that I saw on the subway last week. Um, and I just liked it, and I think it's important as we age, for women to like know things are gonna change and like love yourself through it. So give me laugh lines and wrinkles. I want proof of the jokes we shared. Engrave the lines into my face like the deep like the roots of a tree that grow deeper with each passing year. I want sunspots as souvenirs for the beaches we laid on. I want to look like I was never afraid to let the world take me by the hand and show me what it's made of. I want to leave this place knowing I did something with my body other than trying to make it perfect. So let's be aging positive here. So why do women seek perimenopause, menopause care? Most of the time when people are actively seeking care, they're hot and they're bothered by it. They're having hot flashes, they're having sleep disturbances, they're really not feeling like themselves, and there's some major changes happening with the cycle. Sometimes people will seek care a little bit earlier because they're noticing more subtle changes and want to take a proactive approach and just get information early. But at the end of the day, everybody's seeking care because they want safe and effective solutions. They want to feel better. Right. So we'll start with talking about what is exactly happening in the menopausal transition and where and who you can seek support from. So menopause in Canada. So I had some fun looking at the StatsCan website to see, what are our demographics right now in terms of population and how many women in Canada are like in the category of perimenopausal to menopause to postmenopause, right? The life expectancy for women in Canada is 84. My face is covering it. Is 84. Many Canadian women will spend up to 40% of their lives in postmenopause, right? So that's the time that you're living where you no longer have a menstrual cycle. Your hormones aren't being produced or fluctuating anymore. So there are millions of perimenopausal and postmenopausal women in Canada. So in 2024, and I had to kind of guesstimate to a degree here because the age at which women enter perimenopause and menopause is very variable. So I just kind of conservatively said anyone over 45. So in Canada, 23% of all Canadians are women 45 and older, which is a lot. And that group of women comprise of 45% of all Canadian women. So 45% of all Canadian women are 45 and older, and 23% of all Canadians are women who are 45 and older. So that's a big chunk of the population that should have comprehensive care and information. Globally, so in 2025, we're expected to have 1.1 billion women who are postmenopausal, who are no longer getting a period, right? And so that does not include the perimenopausal population. So there's a lot, this is a big chunk of the population. And it's a very hot topic right now, and we can kind of see that it's getting a lot more airtime, which is a good thing. All right, so let's define menopause. So is menopause an endocrine disorder that should be treated medically with the same seriousness that we treat other endocrine disorders, such as diabetes or thyroid disorders? Is it a natural progression of aging whereby a woman's reproductive capabilities cease? Is it an empowering rite of passage in a time of major transformation and maturation? Arguably, it's all three. So the terminology is important. So the menopause transition includes the early menopausal transition, and we're going to define this mostly by what's happening with periods. So in the early menopausal transition, what we'll see is 7 or more days of persistent difference in cycle lengths from the previous cycle, right? So if you have a 21-day cycle, one cycle, and then you have a 35-day cycle, and then you have a 42-day cycle, there we're seeing 7 or more days of persistent difference between cycles. Where you're not yet skipping cycles, but you're having that variation. Whereas the late menopausal transition is where you start to skip cycles, where you have, you go 60 days without having a period. So when we start to see that variability start, that's perimenopause. So the early perimenopausal transition will then shift into the late menopausal transition. And then all the way till that you haven't had a period for a year, that's included in perimenopause. And then menopause is a brief moment in time where that's that 1 year mark after your last period, and then moving on, you're in postmenopause. So that's really the terminology we want to work with. It doesn't mean that you can't start, like you may start to have symptoms earlier than your cycles start to change. But it doesn't, and this is where the definitions get a little bit murky because could you be perimenopausal without having that 7 days plus or minus variation between your cycles? It depends. Depends on what criteria you're looking at. So the most kind of widely accepted criteria. It's called the STRAW criteria, the stages of reproductive aging. Um, and so this kind of shows us like the menopause transition and postmenopause and what we're going to see happening. So in the menopause transition, like we talked about, we had the early and the late. This is considered perimenopause. And then it goes with some supporting things that we may see on lab work or on ultrasound, and the symptoms that are most likely to be common to occur. So, and this is not black and white. People don't always fit the lovely scientific charts, but this is a good overview so you can understand kind of where we're gauging. And when I do my charting, I always like to note when their last menstrual period was, where I think they are in their menopausal transition, because it kind of helps me gauge the conversations that we'll be having. So why women need comprehensive care, like I said, there's age and then there's this major hormonal shift. We're getting older and the menopausal transition is inevitable. However, like there are some things we can change and there are things that we can't change. So the fact that we're getting older and we're going to enter perimenopause, menopause, those inevitably are non-modifiable things. We can't do anything about that. But what we do know is age and menopause, they do confer some different risks for our health, right? Versus non-modifiable risk factors. That's, how much alcohol we drink, whether or not we smoke, our body composition, like these type of things we have some control over to a degree, right? And we can make changes and decrease the risks associated with certain conditions by modifying the risk factors that we are able to. So I want to kind of go over these terms of non-modifiable risk and modifiable risk because we're going to talk about them when it comes to conditions that often present themselves in menopause. So to define like a little bit more what's happening hormonally, in our peak reproductive years, this is where if you're not on any type of hormonal contraceptive, you'll be having a cycle that is somewhat regular, unless you have a condition that creates irregular cycles. But typically here, we're seeing a pretty standardized fluctuation in hormones that happen on a monthly basis that correlate with getting a regular period and regular ovulation. In perimenopause, we get what's called compensated failure of the hypothalamic pituitary axis. Translation means the brain starts to have to yell at the ovaries to try and produce hormones and ovulate in the same way that they used to, but the ovaries can't do it and they're not able to. So what we start to see happen is cycle variation. Maybe the cycles get shorter. Maybe there's more irregular bleeding. Maybe the cycles get longer because the body's not able to ovulate. And we'll see more variable levels of estrogen and progesterone. And often, what this manifests into is like PMS symptoms really begin to change. PMS, especially when it comes to mood, is really the nervous system's response to these fluctuations in hormones. The nervous system can't always handle these huge fluctuations, and that can make mood changes present themselves. So that's where a lot of the times people will describe it as like their PMS is 10 times worse than it was. And often there's some weird cycles where they think they're going to get a period and the period never comes, and it can be a little dysregulating. So loop cycles is a very specific phenomenon where in perimenopause, which the brain is trying to tell the ovaries to ovulate, if they're not able to, you get a period, but the brain's still telling you get a bleed, not necessarily a period, and the brain's still trying to tell the ovaries to ovulate, and you might get a really short cycle or a really long cycle, and it can manifest in some more pronounced PMS symptoms of breast tenderness and PMS and sleep disturbances. So the loop cycles are really where periods start to get loopy and they're not predictable. So this is where I always like to tell people, and when they are in perimenopause and their periods are starting to change, our goal is never to try and regulate the cycle. It's to really help manage the symptoms while cycles are irregular. So post-menopause, really like when you're haven't had a period for a year or two or three, your ovaries really aren't producing much hormone at all. Like I would argue to say like very, very minimal or negligible amount of hormone. And because you're not ovulating, you don't produce any progesterone in any significant quantity. So we really do have a flat lining of the estrogen and progesterone cycling. So what we see is it's the symptoms people will come in because they'll feel and they'll notice them, irregular menstrual cycles, worsening in PMS, sleep disturbances, hot flashes, mood changes like low anxiety, a low mood or anxiety, some metabolic changes or weight gain, some hair loss or hair growth in different areas, some hot flashes, like hot flashes and night sweats are very common, libido changes, joint pain vaginal dryness, irritation, pain with intercourse. So these symptoms are typically caused by the hormone levels changing, right, dropping. Um, and the hormones are changing because we are getting older. So there is this like age and hormonal shift happening at the same time. Here are the signs and the risk factors. So aspects that you don't necessarily feel or notice. And for healthcare practitioners, these are the things that we're worried about, just as much as your symptoms. We want to make you feel better, but we also want to make sure that the things that you can't see and necessarily feel, we're looking out for and we're taking a preventative approach there because we do want to support your overall health, not just put a band-aid on symptoms. So we'll see cardiometabolic changes happen. So changes to the cholesterol levels and blood sugar dysregulation. So a lot of the time people will say, oh, I've never had high cholesterol. I've never had blood sugar issues. And we start to see that things are high or different on their blood work in the absence of them living their life any differently. They could be eating the same, exercising the same as they had been, but their levels are starting to change. Increase in blood pressure, increase in weight, decrease in muscle mass, breast cancer risk increasing, and breast cancer risk just inherently increases as we age. And then bone changes. So again, we can't see that unless imaging is done, but we do know with age and with loss of hormone, there is bone loss that starts to happen. And I put a little asterisk around cardiovascular disease risk, breast cancer risk, and osteoporosis risk because there are some, like when we talk about menopausal hormone therapy and its influence on these risk factors, depending on what's happening, it can increase the risk or decrease the risk based on what is implemented. We'll get to that shortly. Who can help you with these changing signs and symptoms? This is like I did a similar presentation with a colleague of mine a few years ago, but this is something that I have added because I think it's really important for the population in Ontario to understand like where can you get care? Um, so we have many options, right? OHIP providers. So we have our medical doctors, nurse practitioners. They're kind of in an area of both OHIP coverage and privately billed. And then we have our virtual medicine platforms like Maple and Felix that are comprised typically of both medical doctors and nurse practitioners that are not typically OHIP covered. So as a naturopathic doctor, when we look at the things that we need for perimenopause and menopause care, we need screening blood work. We need cervical cancer screening, both of which I can do, although cervical cancer screening is changing in the next year. So things may shift a little bit there because I cannot do HPV swabs. Pelvic exams, so that's actually like doing vaginal exams, speculum exams. That's something that I can do. I can't give you a requisition for a mammogram, but you can self-refer. We'll talk about that later. Bone density scans, I can't refer for. Referral to specialists, I can't as well. I can prescribe hormones. There are some limitations there. Non-hormonal options for hot flashes, night sweats, often which are SSRIs. I cannot do that. Obviously, I big on the naturopathic modalities like botanical medicine, diet, nutrition, lifestyle, acupuncture, I'm not OHIP covered, right? So there's pros and cons to working with a naturopathic doctor. Medical doctors, obviously, like they're pretty unlimited in terms of their scope. They may not have as much time or expertise when it comes to diet and lifestyle modifications. And obviously, they don't have training in botanical medicine or acupuncture. But they're typically OHIP covered, which is great. Nurse practitioners, they're a great option to work with, and this is where I often will collaboratively work with nurse practitioners, um, and they're able to prescribe, refer, requisition imaging. Um, they may not have as much expertise in the nutrition and diet and lifestyle elements. And then in terms of being OHIP covered, it's very interesting. And this also may be changing this year, but typically their visits are not covered, but their labs are. So some nuances with working with a nurse practitioner. Virtual medicine platforms, they're a great option for people, but typically you're not going to get uh, it depends, right? But you may not get as comprehensive care in terms of having that primary care. It might be more acute or symptom or specific condition oriented care. Um, and they're typically not OHIP covered, or again, a little bit of a gray area. So obviously, like I know my own practice best, but I do have limitations in what I can do, and there obviously are some barriers for working with a naturopathic doctor when it comes to costs associated. However, I think the biggest thing is the luxury of time, right? The initial appointment is 90 minutes, and we use that whole 90 minutes, let me tell you, and then follow-ups depending on how much time we need are either 30 or 60 minutes. And what's most important is like I ensure everyone gets the care they need via collaborative care. Like if I need to work with alternate with other practitioners to make sure everyone's getting the comprehensive care they need, I am very it's very important to me that everything is facilitated. One other thing to look at when you're working with any provider when it comes to menopause care, there is a Menopause Society. It's an American found like society, like Menopause Society, that actually certifies practitioners in and having knowledge around comprehensive menopause care. I did my certification back in 2022. I'm going to be redoing, you have to redo the exam every 3 years. So I'm going to do that again this year in 2025. But you can actually look on their website for Menopause Society certified practitioners, many of which are doctors, naturopathic doctors, and nurse practitioners. Okay. So getting older, getting older and hormonal shifts. Let's embrace it. Like I said, we want to think about the non-modifiable risk factors for disease. And so when we get older and we have this major hormonal shift, menopause, it increases our risk for bone loss, it increases our risk for cardiovascular disease, and it increases our risk for breast cancer. And so we're going to go into each of one of those in detail. So just again to reiterate, non-modifiable risk factors are things that you can't change. So awareness of these factors is key so that you can mitigate these risks and take proactive approaches. And also if there are risk factors present, so let's say someone does have a really high risk for breast cancer, it's important to take these risks into consideration when we're deciding on the treatment approach. Versus our modifiable risk factors, those are things about your life and your health you can make changes to. So you may need support or guidance identifying these and implementing interventions for change. And I personally think this is where naturopathic doctors really excel and can help people make those changes. So reducing breast cancer risk. So age is one of the greatest factors in breast cancer diagnosis. So if we look at this study, it shows us we've heard of this number, 1 in 8 women in their lifetime will have a breast cancer diagnosis, right? And so we could see birth to death. This is 12.9% of the population, women, so 1 in 8 women or 125 out of 1,000. So we can see here that the highest, like at 70 or older, 7% of women, the 1 in 14 women will have a breast cancer diagnosis. 60 to 69, that's a pretty high range there, 1 in 28. And then we have the 50 to 59 and the under 49 category, right? So we can see there is increasing risk of breast cancer diagnosis with age. Personal or family history of breast cancer, genetics, ethnicity also can increase risk. Age at which you get your first period, whether or not you've given birth, had breast, like being a breastfeeder, also increases risk. And so there's two risk calculators that I'll often, I do it with every patient that we're going to prescribe hormones to, and we'll talk about the risks associated with hormones in a moment. But there's these two risk calculators that you can look up and you can actually do yourself. That will show you, like, based on an algorithm and studies, what is your risk? And this primarily includes our non-modifiable risk factors. So we'll go over what those look like in a moment. Modifiable risk factors, and I always like to show people this. So this is amount of people who have a breast cancer diagnosis over 5 years' time, aged 50 to 59, and this is based on the UK population. So what we see here is there's 23 cases of breast cancer diagnosed over 5 years per 1,000 people. And there's an additional 5 cases that we can attribute to women who are drinking more than 2 units of alcohol per day. So that's a modifiable risk factor. Smoking also increases the risk. Having a BMI, so a body mass index, or kind of your body composition, a BMI over 30. So that an optimal BMI, and there's some nuance around BMI, is going to be around 25, or like 20 to 25 is considered like the healthiest BMI. That, again, a caveat, that's not a be all end all. But having a BMI over 30, and you can easily look this up online, like calculate your BMI, really does substantially increase risk of breast cancer. So it's important to understand. And what we see is like a huge modifiable thing that we can do is exercise. So there's 7 fewer cases in those who exercise at least 2.5 hours or 150 minutes per week of exercise. And exercise, I always like to emphasize that exercise and physical activity are very different. Exercise is intentionally going to do like a fitness-oriented activity, like going to the gym, resistance training, doing cardiovascular activity like jogging or elliptical, doing something that's intentional exercise that you wouldn't be able to have a leisurely conversation doing is exercise. Whereas physical activity is your walk to work. Physical activity is picking up your kids from school. Physical activity is, your commute and doing all those stairs on the subway. Biking is physical activity. It's not necessarily exercise. So just to define that. So we'll talk a little bit more about breast cancer later, but let's talk a little bit about cardiometabolic health. So cardiometabolic health, that's looking at like blood pressure, cholesterol, and really when our cardiometabolic health isn't managed, it puts us more at risk for stroke, heart attack. So what we see happen with age and also the menopausal transition, weight begins to shift. Often cholesterol levels will go up. Blood pressure often changes, going up. Sometimes there's some blood sugar regulation, and inherently like inflammatory markers will increase also. And all of those things put us at more risk for cardiovascular events. What reduces risk is really like making sure that all of these things are optimal and managed. Other things that can increase risk for cardiometabolic issues are smoking, alcohol, primarily being inactive. So when we think about how do we support this population, menopausal, perimenopausal women, where we're beginning to see these changes, obviously conventionally medication it can be indicated and can be an option. Both conventionally and naturopathically, we're going to talk about diet and exercise. My own one caveat there is often we need a lot more time to talk about what diet and exercise need to look like and how people are going to make those changes. So with botanical medicine and so that's using our herbs and very targeted supplementation, and obviously like kind of amping everything up is often what I'm doing in practice. So that's a plus plus plus. It's like more time, a little bit more individualized, a lot more perhaps, and just really doing some early testing and more comprehensive testing to make sure that we can make sure things are changing. So when it comes to bone health, again, this is one of those things that's going to change in our menopausal population. When aging and that hormone loss, inevitably there's going to be some bone loss. So what supports bone health? Resistance training, weight training, optimal protein intake, calcium, vitamin D3, K2, like making sure that that's an optimal intake, both dietarily and supplementally. Making sure your diet is not one that's inflammatory, so eating a healthy anti-inflammatory diet. Obviously, we'll talk about estrogen in a moment. It's more about prevention, not necessarily treatment of bone loss or osteoporosis. And what increases our risk of bone loss is just it's like the age, menopause. Genetics is actually a really big part of bone density. So family history is always important to understand. And if there is a family history of osteoporosis, how that might be influencing your own risk. Medication history and health conditions also contribute to bone health. So it's important that we always take a thorough history there to make sure that we're taking an approach that makes sense. Smoking, being underweight, actually is a risk for more bone loss and fracture. Alcohol in excess also contributes to more bone loss and vitamin D deficiency. So again, thinking about what we do conventionally and what we our options naturopathically. Conventionally, typically getting a bone density screening, you have to meet a lot of criteria to even get that. If one does indeed have bone loss and it's osteoporotic, then medications are often recommended. Diet and exercise are important to really make sure we have those foundations there. And then from a naturopathic standpoint, both naturopathically and conventionally, like there is those options of menopausal hormone therapy influencing bone health. And then naturopathically, yeah, there are supplements, obviously diet, exercise, we're going to really amp up and refine. When it comes to the symptoms, the hot flashes, night sweats, sweet sleep changes, what we know reduces these symptoms, just kind of the baseline, stress management, consistent sleep, we know that that's going to help. Exercise may or may not help for people. And then menopausal hormone therapy is a first line intervention that will help most people's hot flashes, night sweats, and sleep changes. And that's something that can be implemented conventionally or, with a naturopath who has that prescribing scope. What increases symptoms? So these vasomotor symptoms, the hot flashes, night sweats, and which will often influence sleep changes. Smoking and alcohol, we know, can be influencers with increase those symptoms. And there is some evidence to point that there's links between those who have vasomotor symptoms and those who may also have some cardiovascular disease or perhaps some poor bone health. So we don't really know the exact link there, but there's some more and more evidence kind of showing us that there could be a link between the severity of symptoms and perhaps some other signs that could be happening or risks. All right, so let's talk about menopausal hormone therapy. And this is the way that I like to look at menopausal hormone therapy. So here's a little bit of analogy, and I like cake, so I'm going to use a cake analogy. So menopausal hormone therapy is really the icing on the cake. You can't just have icing, right? You need cake. Well, you can, but like it's not going to be as good. It's going to be too sweet. So you can have cake without the icing, right? So how this translates, like I love cake, but the translation is menopausal hormone therapy can be a beneficial piece of comprehensive menopause care. But you can also have a smooth menopausal transition with comprehensive care that does not include, that excludes menopausal hormone therapy. So you can have the cake without the icing. So only implementing menopausal hormone therapy, so without comprehensive care, it's really not as beneficial. We want to be looking at everything. And I love comprehensive care. So hormone replacement therapy. A little bit about the terms here. We don't really call it hormone replacement therapy anymore because it's not actually replacement. We're not trying to get people's hormone levels to the levels that they had when they were in their peak reproductive years. And then we'll talk about that in a moment. Hormone therapy is currently like used interchangeably with menopausal hormone therapy. It's just not specific. So when we're specifically talking about supporting women with hormone therapy in menopause, we're going to be using the term menopausal hormone therapy. This is where it gets confusing because there's a lot of terms that can be thrown around, and if unless we really know what that term means, then we could be misinterpreting some information. So estrogens, and there's like umbrellas. So estrogens is an umbrella that includes both synthetic estrogens and bioidentical estrogens, right? Progestogens is an umbrella that includes our synthetic progestins and our natural progesterone. Bioidentical hormones are hormones that are chemically identical to those made by humans. These include commercially available products, right? So you can have something that comes out of a pharmaceutical plant that is indeed bioidentical. Compounded hormones have been custom made and can be bioidentical. Most of the time, they are bioidentical. And then we have our regulated Health Canada FDA approved commercially available products. And these can be bioidentical or they can be synthetic non-bioidentical. So I have my next slide, and I'm in the office so I could show my little props here too. I'll just jump right to it. Yeah. So here is some common menopausal hormone therapies. We see our estrogel, which is bioidentical estradiol, estradot, which is again bioidentical estradiol. But they look like they're coming out of a package. They're a pharmaceutical, but they are indeed bioequivalent forms. We have our progesterones. Um, then here's a like what compounded hormones often look like. Astalis and Duaviv. These Duaviv does not contain bioidentical hormones. Astalis contains bioidentical estrogen, but a synthetic progestin. So there's nuance in what hormones have what components. Go back, yeah. So terminology, we have estrogen therapy, progesterone therapy, and then menopausal hormone therapy. It's typically estrogen progesterone therapy. There also we can also utilize androgens. So it's not uncommon that it will be indicated for someone to use testosterone or DHEA. They're not standard in menopausal hormone therapy, but they can be helpful. All right. I also added this slide, and it's going to be very helpful for prospective patients because a lot of people want to know, okay, well, how much is this going to cost? So pharmaceutical ready-made products are typically covered by drug benefit plans if you have one. And it doesn't matter who's prescribing it. Some people are like, well, if my doctor prescribes it, it'll be covered. And it's like, well, it doesn't, whether a nurse practitioner prescribes it, I prescribe it, or your doctor prescribes it. If you have coverage for the formula, then you should have it covered by your drug benefit plan. So I've kind of broken it down here to pretty typical prescriptions that are written for menopausal hormone therapy. So at most, if you have your transdermal estrogen, your progesterone, and your vaginal estrogen, which can happen, you're looking at about $150 a month of those medications alone, the hormones alone. When we look at our custom formulas, our custom compounded formula, these are typically not covered by drug benefit plans because they don't have a DIN, a drug identification number. And here are some common common compounded formulas and how much they cost. So they're not really that different in terms of cost. Often I will be doing more compounds for the vaginal estrogens, and then the odd person, there's some interesting uh, research around actually using a little bit of a type of estrogen topically in face cream. So that can be an option, but here are all the prices here. When we talk about what we're doing when we're adding back in hormones, so in menopausal therapy, we're not trying to recreate this. We are not trying to recreate the cyclic fluctuations of our peak reproductive years, nor are we trying to recreate the levels of our peak reproductive years. Rather, we're going from here to here, right? So we're going from like a baseline of not very much at all to just lifting up that baseline so that we're not having nothing. Or if we're having a lot of fluctuations in perimenopause, we're just buffering the low. That's what we're doing if we're adding hormones in perimenopause. We're buffering that dip that's happening and leading to symptoms. Okay, so talking about the benefits of menopausal hormone therapy, it's really important that we kind of set the stage by how important it is to do an individualized risk benefit assessment and always know that any decision making is shared, right? It's shared between the prescriber, the practitioner, and the patient, right? It's not a decision made just by the patient or just by the practitioner. It really has to be made together. So the benefits, what we know is menopausal hormone therapy is approved as first-line therapy for vasomotor symptoms. That's your hot flashes and your night sweats in appropriate candidates, right? Um, there's nothing that necessarily matches its effectiveness. I will, if I'm from a study standpoint, I will argue that we can also get really good menopausal symptom relief with our naturopathic therapies. But sometimes I'll explain it to patients. Sometimes it takes a lot of supplements to do what perhaps the menopausal hormone therapy can do a little bit easier. So it really depends on the case. And with implementing menopausal hormone therapy for the hot flashes and night sweats, we do see shift happen quite quickly. Like it usually you see it within a month, people's symptoms typically shift for the better and resolve. Bone health. We know that in menopause, in that first 5 to 7 years following the menopause, following your last menstrual period, there is bone loss that's inevitable. And estrogen is really responsible for preventing that bone loss. So hormone therapy can be indicated for preventing some of that bone loss. But there is an element where when you do stop the hormone therapy, then you are going to get that bone loss once you do stop. So we can prevent the time at which that bone loss happens. So we just want to keep that in mind. So we're not seeing someone who has osteoporosis be prescribed hormones to then improve their bone density. That's not how hormones are prescribed, or they don't have that indication. But for women less than 60, within 10 years of menopause, menopausal hormone therapy is likely an appropriate intervention to help maintain bone density. Again, and I'm going to preface this, you can't just do the hormone therapy. You want to make sure you're telling those bones they need to stay strong, exercise, diet, and lifestyle. So yeah, like I said, what happens when you stop menopausal hormone therapy? When you do discontinue, you do lose the protective benefit. So big question is always, when do you stop menopausal hormone therapy? And the short answer is when the risks outweigh the benefits. And that's a conversation that I like to have with people annually. It's doing that risk benefit analysis. So genitourinary symptom of menopause, this is vaginal dryness primarily, but it's a collection of signs and symptoms associated with estrogen deficiency. So our vaginal, urinary, and vulvar tissue are very estrogen sensitive. And in the loss of estrogen, there are inherent changes that happen. So some people will experience dryness. Most people will experience dryness. There's irritation, burning, more frequent urinary tract infections, pain with intercourse. And what we know is low-dose vaginal estrogen therapy is highly effective at resolving this. And it's generally safe and well tolerated. So that's a really big benefit of menopausal hormone therapy, specifically vaginal estrogen. And you can just do vaginal estrogen and not do systemic therapy. So that's often a common prescription that we'll do. Sleep. So we do see improvements with sleep on menopausal hormone therapy, and this is primarily because there's less hot flashes and night sweats. Cognition. The brain doesn't love big fluctuations in hormones. So it kind of stresses out the brain, and that's where there can be some lower processing or memory changes in perimenopause and early postmenopause. And once the body gets used to its new baseline, usually those resolve. So some people will find that there is some improvement in their cognitive symptoms when we implement menopausal hormone therapy because we're buffering that fluctuation a little bit. Body weight. There's no evidence that menopausal hormone therapy can put on weight, nor do we know that it can like help with weight loss. However, it may shift body composition a little bit, especially with that fat accumulation around the abdomen, and it can help with sleep, which then can help you make better changes with your diet and exercise. So it's kind of a more of an indirect benefit on weight. Cardiovascular benefits of menopausal hormone therapy in women less than 60 and less than 10 years since they entered menopause. So they're recently menopausal or perimenopausal, and there's no evidence of existing cardiovascular disease. We know that there's no increased risk of cardiovascular disease. So this is all about the timing hypothesis. And we do have some research to kind of show and validate that menopausal hormone therapy may actually reduce the rate of atherosclerosis or like plaque formation progression and reduce the risk of all-cause cardiovascular disease mortality. So there is some benefits for cardiovascular health with the implementation of menopausal hormone therapy. Also, we see some improvements in glucose regulation and the decreased incidence of diabetes in those who are on menopausal hormone therapy. All this to say, we would never have someone coming in with purely metabolic concerns and suggest, well, you should just go on menopausal hormone therapy. It's not a first line approach. If they had no other symptoms, we'd really be working on other approaches to support their metabolic health versus adding in menopausal hormone therapy as the only solution. The risks. All right. So again, I'm going to emphasize the importance of an individualized benefit risk assessment and shared decision making. So with cardiovascular disease, the risk is really about when the hormones are implemented. So menopausal hormone therapy should not be implemented or like initiated if it's been more than 10 years after the last menstrual period. And so the timing hypothesis posits that the age and time since menopause influence how the menopausal hormone therapy and cardiovascular disease are going to influence each other. Route of administration and dose also matter. And so what we are seeing more is that transdermal estrogen, that's typically what is prescribed now, so in a gel or a patch, provides no harm, but it doesn't necessarily confer a ton of benefit. Whereas if you implement an oral estrogen after 10 years, we know that significantly increases risk. Presence of cardiovascular risk factors is not a contraindication. Like if there are some risk factors of cardiovascular disease, it doesn't mean that we cannot implement menopausal hormone therapy. We just want to make sure that these cardiovascular risks are being managed, and we're going to be thinking about the form in which we're initiating the hormones. Endometrial hyperplasia. So that is when the endometrial lining is stimulated and grows, but it doesn't shed. So this is why progesterone needs to be implemented if estrogen is being implemented. And someone has a uterus. If someone doesn't have a uterus, then they're a candidate for estrogen-only therapy. If someone has a uterus, in order to avoid endometrial hyperplasia or like increasing the risk of endometrial cancer, you must use a progestin or progesterone in line with estrogen. So what we do know too is the type of progesterone. Based on the studies, we know the type of progesterone and form of progesterone is going to offer more protection versus others. So that's a very important conversation that we have in practice around making sure we're prescribing in a way and recommending a dosing strategy that really protects the endometrial lining. Breast cancer risk. So this is the most complicated area to talk about, but it's worth attention because it's important to understand what influences one's risk. So there are three big risk factors that we know of off the bat, being female, having breasts, and increased age. So breast cancer is the most commonly diagnosed cancer in Ontario women. 1 in 9 women will get breast cancer in their lifetime, as the stats say today. Breast cancer has one of the highest survival rates of all cancer types in Ontario. This is very Ontario specific data, which is great. I got this all from the Cancer Care Ontario website, and so this is the data that they've compounded. And the chance of getting breast cancer increases with age, and usually in Ontario, breast cancer usually develops later in life, so 40 and above. In 2024, there were 13, so there are about 13,000 women will get breast cancer, so that's already happened, and 3,500 will die from it. Only 5 to 10% of women with breast cancer have a family history of the disease. So family history isn't as important as other risk factors. It's important that we need to consider it, but there are other elements that influence cancer risk. So fewer than 1 out of 100 women are at high risk of getting breast cancer, and high risk is having a 20% risk in your lifetime of having breast cancer or greater. And we'll see what that means in a moment. So this is a complex issue. When it comes to menopausal hormone therapy, what we know is estrogen-only therapy actually reduces breast cancer risk, whereas estrogen combined with progesterone, which most people need because they have a uterus intact, if we're using a bioidentical estrogen, there is no increased risk for the first 5 years of use. After that, there is some risk that is added to your own baseline risk. So we always want to think about really counseling people on their modifiable risk factors, like what they can change, their diet, their exercise, their body composition, whether they smoke, whether they drink, making sure we have all of those as dialed in as possible, reducing the risk. So breast cancer is more difficult to detect with mammography when breasts are dense. So that's another conversation that I'm starting to have more and more with patients in practice, because mammography now is really reporting on breast density, which then we can have conversations about different types of screening and how hormones influence breast density. Because we know that menopausal hormone therapy can increase breast density. But as we get older, breast density typically decreases, right? But if we keep the hormones in place, we can see that actually would increase your breast density relative to where it would be without hormones. And dense breasts, as we've talked about, are more difficult to detect cancer in. The breast cancer, this is just kind of talking about menopausal hormone therapy and breast cancer. So the same kind of cases of women aged 50 to 59 over 5 years' time. So per 1,000 women aged 50 to 59 over 5 years' time. In those who are using a oral estrogen and a synthetic progestin, we know that there are an additional 4 cases. Like there is some risk associated with that type of menopausal hormone therapy regimen. There are 4 fewer cases in those who use estrogen alone, right? So we're often like, oh, estrogen, bad breast cancer, but it actually is the progestin component that confers more breast cancer risk. So those who are using bioidentical progesterone, we know that there's no increased risk for the first 5 years of use. Beyond that, the safety data is less clear. So just a little bit more information on dense breasts. So we do know that menopausal hormone therapy can increase breast density, and breast cancer is more difficult to detect with mammography when breasts are dense. So additional screening is important for people with very dense breasts to advocate for screening in screening ultrasound or potentially MRI, depending on what other risk factors are present. So dense breasts are common, and for women aged 40 to 74, 43% of those women have dense breasts. And like I said before, breasts usually become less dense and fattier with age, unless there's hormone therapy. Um, so here's a little bit of a kind of looking at how the percentage of women who have dense breasts changes as in the 40s, 50s, and 60s. You cannot feel your breasts and say whether they're dense or not. You can only see this on mammogram or ultrasound. There's a great website, Dense Breast Canada, which actually has a lot of information and talking points. So should you want to talk to your doctor about making sure that you're having adequate screening, and if your breasts are dense, then to make sure that you are indeed getting additional imaging techniques done, like ultrasound or MRI. So that makes it more it's it's more accurate in detecting things than mammogram for people with dense breasts. So breast cancer screening in Ontario has changed. So now people aged 40 to 49 can get mammograms. Typically, previously, in the absence of significant risk factors, women were starting their mammography at 50. Now it's being recommended that people start at 40. And why the change? This was really interesting to kind of tease through, like what does this actually mean starting at 40 versus starting at 50 for how it changes things. And so what we see here is the big change is up to 9 deaths from breast cancer will be avoided over their lifetimes if screening is starting at age 40. So per 1,000 women, 9 deaths from breast cancer will be avoided versus 7 deaths from breast cancer being avoided if screening starts at age 50. So you can read this once the video's up and take a better look at that. I've also included the link to reading more about it here. But these conversations are good to have with a healthcare practitioner to really understand what type of screening you should get, how to get screening. So you can actually self-refer. You can go to the Ontario, the Cancer Care Ontario website and find the phone number and just call to book your own appointment, have screening facilitated. Here's a little bit of an infographic around breast deaths. So categories C and D are considered dense, D being the most dense. And I just want to emphasize the importance of lifestyle factors, right? So it's putting it all together. And what we do see is there are risk factors that are modifiable that influence breast cancer risk more than hormone therapy, even with synthetic progestins. So breast cancer, some take-home messages. Increase in breast cancer may be related to the duration of menopausal hormone therapy use. We know the risk may be lower using a micronized bioidentical progesterone versus a synthetic progestin. The risk associated with breast cancer equates to an incidence of less than 1 per 1,000 women. This is similar or lower than the increased risk of sedentary lifestyle, obesity, or alcohol consumption, as seen on this page. Risk of breast cancer decreases progressively after you stop menopausal hormone therapy. But your breast cancer risk should be evaluated before your menopausal hormone therapy is initiated, and I would argue ongoing, right? Because the risk factors may change. Um, and annual mammograms with additional ultrasound or MRI would be good to consider, especially in those who have high density breasts. And then otherwise making sure you're staying on the screening recommendations that are recommended by your healthcare provider. So take home message, and then take home message is we know that menopausal hormone therapy reduces cardiovascular risk. We know that it reduces colorectal risk. We didn't really talk about that, but it does. But we know that there is some increased risk of breast cancer. So dependent, and this is all of these asterisks are depending on what type of menopausal hormone therapy you use when it was started and duration of use. Like there's a lot of different factors that factor into risks. All this to say, and this is a good kind of quote from the British Menopause Society, this illustrates how inappropriate it is to discuss the HRT association with breast cancer without any consideration that the risk factor for one health condition may protect against another. So, so this is kind of a way of putting it all together that it's not a clear answer of this causes this and this you should do this if you want to live longer. It's there's a nuance to it, and it's really about doing an individualized benefit risk assessment to understand what is most appropriate for a person. Right. So for example, I just like to kind of put it all together. If a person comes into my office, they're 52, they have hot flashes, night sweats all the time, they're not sleeping well, they're feeling anxious and noticing brain fog, they're having pain with intercourse, and they're having the vaginal dryness. Their last period was about a year ago, so they're just beginning to enter, they're hitting menopause, if you will. They're up to date with their PAPs and mammograms. Everything is clear of pathology, and they have category A breast density, so really, really fatty tissue, so not dense breasts. Um, and although the BMI is in the normal range, she noticed that she's gained 10 pounds, but her BMI, let's just say her BMI is 25. She wants to know about menopausal hormone therapy and whether or not she's a good candidate. So we know that menopausal hormone therapy are going to confer some benefit for all of these things that she has coming in with. And what I would do with her is I'd make sure that she doesn't have any of these risk factors. So these are things if someone says they have this or if we identify this, I'm gonna take a pause on initiating hormone therapy. So what we know from her breast cancer risk is we've actually like I'll use a calculator that's specific to the individual. There's one calculator that's a bit more simple, and then there's one that's more complex that includes we can actually put in the breast density, we can put in lots of different family history. So depending on the patient, I'll choose the breast cancer risk calculator just to kind of understand what their baseline risk is. So she has a low risk like she's on the lower risk of developing breast cancer. So we know that is a positive in terms of our decision to make to implement menopausal hormone therapy. I also like to do this cardiovascular risk calculator, and I'll put their age, I'll put their blood pressure, I'll put their cholesterol level, so that we can make sure they are a good candidate from a cardiovascular standpoint. So again, here we see a low risk. And so this is your typical good candidate for initiation of menopausal hormone therapy. We've done the risk calculators. There's a low breast cancer risk, and there's a low cardiovascular disease risk. They're less than 60. They're recently menopausal, or they are indeed perimenopausal still. They have a normal weight. They have normal blood pressure. They have an active lifestyle, and their cardiovascular risk is low. So she's a good fit, and I would be happy to prescribe, making sure that she has all the information she needs um, to make that decision for herself as well. All right, talking a little bit about naturopathic menopausal support. What it looks like to work with me, I think this is really important to understand. So the 90-minute initial is 350, and it is 90 minutes. We go over everything. It's really important that I get a really thorough history and begin to have those nuanced conversations around how we're going to work together. If we do need to do labs, typically we're looking at about $150. And because I'm not OHIP covered by my labs, you would need to pay out of pocket for those. It can be more depending or less depending. Typically, the second visit is either 30 minutes or 60 minutes. And that's usually when we would prescribe if we were going to prescribe. There's some occasions where I'll prescribe on the first visit if we have all the information that we need and the patient feels that they have enough information to make that decision, and I feel like I have enough information that we can make that decision together. And follow-ups are usually at the beginning, maybe every 4 to 8 weeks or 3 to 6 months, depending on what we're working on. And I always make sure that we do an annual risk benefit assessment, especially if we're going to be continuing on menopausal hormone therapy. I always like to let people know, how best to come to prepared to an initial appointment. If it's virtual, make sure you have blood pressure readings. That's helpful for me to know. And if you have any up-to-date labs, they're always great to have, because then we won't need to run any labs that you already have recent labs for. It's also helpful when people have tracked their period, they kind of know what their cycle has looked like. And if they've had a recent mammogram and that they're up to date with their screenings, their general screenings, and if they have copies of those reports, those are also helpful to have. So naturopathic medicine, like at the end of the day, like I always like to make sure we've got you covered. We are medically trained, but we are naturally focused. We're always looking at the root cause. How can we really support a healthy foundation? When we're building a pyramid, we need to start with the bottom. It's important that care is evidence informed, and it's important that we do thorough intakes and individualized treatment plans. Another really important part of care is resonance. Does the plan resonate with the person? You could be a perfect candidate for menopausal hormone therapy, but it doesn't really resonate with you. Great, no problem. Let's make sure we take an approach that does. So working with a naturopath, it's really not about the prescription, right? We need those foundations, that diet. Like I am always harping to a degree about exercise for people because it's such an important part of health and it really does reduce so many risks. Stress management, herbs, nutrients, like working with all of the diverse and like individualized ways we can put things together. And then like that kind of like icing on top is the menopausal hormone therapy if we choose to implement it, if a person is a good candidate. So there's no right or wrong way to approach menopause care. And the important things are get informed. You do you. You don't need to do what your neighbor's doing or your best friend's doing. You got to do what's good for you and be mindful of those decisions that you're making or the information that you're receiving, depending on what sources they're coming from. And I started with a poem, so I'm going to end with a poem, and I love this poem. Out beyond ideas of wrongdoing and right doing, there is a field. I'll meet you there. So it's not about right or wrong. It's about, what's right for you, what resonates with you. Okay, so thank you so much for attending, and I'm going to stop the recording and we can answer some questions.